National surveys show that 1 in 10 Ugandans do not go to health facilities because they're too far. In a country where health emergencies continue to contribute significantly to the disease burden, this is cause for concern. Victims of choking, drowning, traffic accidents, and any other health emergency could realistically be saved if they're put in an ambulance, taken from the scene, stabilized, and arrive at a health center where they're immediately receiving urgent medical attention. This evening on NTV Panorama, we'll take a closer look at the state of Uganda's medical emergency services. About 54% of persons in developing countries that are pronounced dead as a result of health emergencies could have been saved, according to a World Health Organization 2018 study. Here in Uganda, the statistics could eclipse the global average for developing countries in a country with a moribund health sector, void of emergency services, and one of the highest road accidents and alcohol consumption rates in Africa. In 2022, the World Health Organization ranked Uganda among the countries with the highest traffic death rates in the world, estimated at 29 car deaths per 100,000 people. This figure is of concern as it exceeds the average for the African region of 24.1 per 100,000 people and the global average of 18 deaths per 100,000 people. There is also a nexus between gross road carnage and alcohol abuse, as those reeking of alcohol lead to a spike in road accidents. The 2023 World Health Organization statistics cast a pall on Uganda's society, which is ranked as the highest consumer of alcohol in Africa. On average, each Ugandan aged 15 years and older consumes 12.21 liters of pure alcohol annually. Medical experts, including Dr. Tony Luja, a critical care specialist at Mulago Hospital and head of emergency medicine at Makerere University School of Medicine, fears that the statistics could be much higher.
And these are statistics that we kind of get some from police, and it's not very organized in terms of the trauma registry. So there are things we don't even see reaching the registries and statistics. The people who drown in the lakes, the people who die in accidents that never reach the hospitals.
Many road traffic accident victims in Uganda and others suffering life-threatening injuries, predominantly young adult males and school children, are not able to receive essential care within the hour, including trauma care, surgery, and anesthesia care.
So we have death from emergency conditions over 70% of the deaths that we get in this country. And if you go to Mulago, most of the injuries there that require services are now mainly accidents and emergencies that occur. And as you know, emergency is very important. It should be attended to as quickly as you can in order to save lives. When you delay the person, you may never save the person, even if you give as much care as you can. Every minute counts.
The window of opportunity for a chance at survival is narrow for a severely injured patient, as road traffic accidents and other injuries kill more people every year than HIV/AIDS, tuberculosis, and malaria combined. Time is of the essence in what medical practice terms as the golden hour, a critical period of time immediately after an injury when appropriate life-saving medical or surgical intervention can offer the highest chance of survival for a traumatically injured patient.
There is what we call a golden hour in medicine. When you have a life-threatening condition, there is that golden hour in that if intervention is done immediately, which is what the emergency care is, then the chances of survival, the chances of rehabilitation back to your normal self are higher compared to when the care comes in late.
Uganda's road carnage is fueled by the ailing state of its narrow roads and the chaotic border cyclists, given that motorcycle fatalities increased by 51% from 2011 to 2016, according to a study by the World Health Organization. Additionally, the death toll on Uganda's water bodies, where rickety vessels typically not fit for purpose and standard safety protocols such as the provision of life jackets are regularly flouted, contributes significantly to the burden of emergencies. 239 deaths were recorded on Uganda's water bodies, according to the 2020 annual police crime report. Alcohol consumption also increases the risk of health emergencies such as pancreatitis, a sudden and acute inflammation of the pancreas that requires urgent medical attention. Furthermore, obstetric and neonatal emergencies contribute significantly to the burden of emergencies, given the high, albeit declining, pregnancy-related mortality ratio of 228 deaths per 100,000 live births, as indicated by the 2022 Uganda Demographic Health Survey.
When we look at our mothers, most of them die because of emergency conditions. We have bleeding, we have hypertension or preeclampsia, we have sepsis, which are all results of emergency conditions.
There is also an increase in emergencies due to non-communicable diseases such as stroke and cardiac arrests. Such health emergencies are managed through the provision of emergency medical services, which are defined in the Health Ministry Policy of 2021 as the ability to deliver health services for conditions that require rapid interventions to avert death or disability, and for which delays of hours can worsen prognosis or render care less effective. Dr. Luja explains the nature of critical care required in response to emergencies.
It is the first responders that are the most important, because the statistics show between 9 to 10% improvement of survival if the first responders do the basic life support training, which is basic emergency care. And this basic life support, when a person is bleeding, take him down, put him on the side, put a tourniquet, prevent the bleeding, and take him away from the site. The challenge is in Uganda, the first people on the site will take videos for sharing on social media, or if it's a petrol truck, they'll be siphoning fuel.
This medical care encompasses first aid, transportation of the patient from the scene of the emergency to a health facility, the care provided during transportation by paramedics, and the care received at the health facility on arrival.
We also did 3 drills from the airport with CAA, where they were timing all the ambulances that left Kampala to go for the drill in Entebbe and back. Going and back was the same thing. They double the time you took to come back because of jam and people not understanding that you need to clear away for the ambulances.
This suggests that salvageable patients are dying before they reach hospital.
So that is why the topic of emergency care is very, very much important. And we look at it as something that everyone needs to have access to, despite where you come from. Yeah? And the system has to be good enough that it can serve a minister, it can serve a farmer, it can serve a teacher.
In 2018, research into the state of emergency medical services in Uganda foreshadowed a crisis that could cripple the health sector in the event of a global pandemic outbreak. Barely a year before the COVID-19 pandemic barreled across the country, bringing its shambolic services to a shuddering halt. Amongst the major findings of the research, whose principal investigator was Dr. Olive Kobusinje, a trained surgeon, revealed that Uganda did not have a national policy on emergency medical services, and no such policies existed at district level. For instance, ambulances, which are acutely short in supply, almost universally, lack the most basic of equipment and medicines, both to monitor and to treat emergency conditions. It was discovered that advanced life support equipment within ambulances, like vital signs monitors, electrocardiogram machines, defibrillator, and intubation, were missing.
Yeah, this is a Class B ambulance. or you can call it the advanced support ambulance. It has most of the equipments that the patient needs. Before this patient reaches the hospital, it should be having ventilators, it should be having patient monitor, the patient cardiac monitor. It should have syringe pumps to administer drugs that those drugs that can be administered to those critically sick patients, and they can take maybe a period of 5 to 20 minutes and above. So you're giving them maybe this number of drops per hour. Then that's where you use these syringe pumps. It should be having a suction machine. So you use this suction machine to suck and clear their airway. Meanwhile, as you continue to manage the airway and monitor it, then it has an oxygen system. These are 2 cylinders, and its source is here. This is where we get it from. We give to the patient who is lying here. Then we give depending on the condition we are managing, depending on the oxygen saturation of the patient.
The research also revealed that police, laypersons and bystanders were the first responders in the majority of the districts, with figures placing this at 97.4%. Dr. John Nabohe, the Commissioner for Emergency Medical Services at the Health Ministry, acknowledges this deficit.
About 10% of our emergency patients reach hospital using an ambulance. It is only in Karamoja where it is now at 25%. In Karamoja it's at 25%. I think it came because of the insurgents which is there, so people became more organized and more responsive, so that whenever there is an emergency, there are right numbers for you to call, because they're already used to calling for security, so it is easier for them to call for an ambulance, and the ambulance teams are ready to respond.
Health facilities in the country are poorly equipped to manage emergencies. At health center 4s, general hospitals and regional referral hospitals, there are shortages of medical equipment necessary for assessment of patients presenting with emergency conditions. There are limited numbers of emergency care specialist health workers at the facilities. Uganda's doctor-patient and nurse-patient ratio is approximately 1 to 25,000 and 1 to 11,000 respectively. This is way below the World Health Organization recommended doctor-patient ratio of 1 to 1,000. Kabitanya Lukia, a midwife at Mbale Regional Referral Hospital, reveals the resource constraints that hamper emergency response.
Our biggest problem is having one theater with one operating bed, which brings up a longer period from the time the mother comes. You want to take her in for cesarean section, but when there is no space. So if we are helped and given a theater which has at least more than one operating bed, I think I would be the happiest person.
This is worsened by the government's chronic underfunding of the health ministry and the failure to allocate 15% of the national budget to the health sector as per the Abuja Declaration. This means that the public health sector is heavily reliant on donor funding from development partners such as the United States, which gives the government nearly $1 billion annually, much of which is given to the health sector. The funding gap for the emergency medical services in Uganda is pronounced, given that for every $2 the government of Uganda spends, donors are expected to spend $1. Interventions by development partners such as Seed Global Health to train local specialists in emergency care may not be sustainable given the short-term nature of such projects. Critically, the Emergency Medical Services Strategic Plan is grappling with a shortfall of $82.6 million or an estimated 307 billion shillings. In light of these resource constraints, the role of the community comes into sharp focus as an acute care resource, as Dr. Nabohe elaborates.
The lay responders are the first people at the scene, people who are maybe within the market area where there are gatherings. There are people who are on border stages. They are the traffic officers who are ever moving on the road, and the other security personnel, leaders in the communities, and in the workplaces. We would also like to have first responders there. Any workplace which has more than 30 people, there should be 1 or 2 trained first responders. And these first responders help. These are volunteers. They are not paid people.